The ultrasound examination in gynecology is not a screening ultrasound. It is based on clinical indication. The aim of this presentation is to provide you with accurate information on ultrasound gynecology, focusing on the uterus and the endometrium, based on the recommendation of a French scientific group, the CNEOF, and the international group, the IETA. We will mainly use the endovaginal ultrasound. In case of contraindication, we can use the transrectal approach. The ultrasound will be performed during the proliferative phase between day 4 to 6, and we will use a sagittal plane, ensuring that we are really perpendicular to the endometrium. The first approach is the biometric approach, where we will measure the thickness of the uterus and the endometrium, ensuring to include the summation of both layers. In case of effusion, of course, we will not include this measurement in the endometrium. Then we will make a qualitative description of the endometrium on 5 points. Its echogenicity, the endometrial interface, the famous junction zone, if there is any synetia, and if there is presence of intracavitary collection. The first point is the echogenicity, and we will clearly describe whether there are indeed 3 layers and the qualitative aspects of this endometrium, whether it is hypoechogenic, like in the first phase of the cycle, or a perechogenic, as we can see during the luteal phase. The endometrium can also be isoechoic, like in this example, when the border of the edge are poorly defined. We will then describe the appearance of this echogenicity, and she can be homogeneous with regular cysts, like in this example, or homogeneous with irregular cysts. This endometrium can be heterogeneous without cysts, like in this example, or heterogeneous with small cysts inside the endometrium. The second point is to describe the endometrial interface. Usually, this interface will be linear like this and well defined during the first phase of the cycle. It could be nonlinear and displaced by polyp, for example. It could be irregularly or undefined, as you can see in this last example. And sometimes the endometrial interface could be brilliant, as you can see in these 2 examples. The third point to be described is the famous junctional zone. And we can see it very clearly in all these examples. And this junctional zone is clearly well defined during the first phase of the cycle. Sometimes it's impossible to see it, and it can be a good sign for the adenomyosis. This junctional zone could be interrupted, as you can see in these 3 examples, and in this example, it's probably related to fibroma. And as I said before, the junctional zone could be poorly defined, as we can see in the adenomyosis. The fourth point is try to find the presence of synetia. It could become very complicated to be sure of the presence of synetia. It's more easy when we have a collection inside the endometrial cavity. The last point to be described is the presence of intracavitary collection. This collection can be anechoic, as you can see here, or like frozen glass, or heterogeneous. The morphological exploration can be supplemented with a Doppler examination, but care should be taken with very specific technical criteria. The endometrium cavity will be zoomed in as much as possible. We use a low PRF to optimize the sensitivity. A wall filter will be applied, and the Doppler imaging will be described using the Yetta score. This score consists of 4 categories. Score 1, when there is no flow into the endometrium. Score 2, when there is a small vessels inside the endometrium. Score 3, where there is moderate flow, and for 4, when the endometrium is fully filled with the Doppler flow. The appearance of the endometrial vessel can be described. It could be a dominant vessel, as you can see here, such as seen with polyp, a vessel with branch, multiple vessels with unique origin, or a multifocal vessels, as you can see in case of cancer. These vessels can have various appearance, such as being scattered inside the endometrium, or can, on the contrary, circumferential, as you can see here, and it's typical of fibroma. To conclude, in certain cases, an ultrasonography can be combined with the ultrasound. This is performed by injecting a contrast agent like NaCl. It will optimize the endometrial analysis, particularly the evaluation of the endometrial surface. This surface can be smooth, and you can see in this example, or on the contrary, wrinkled, as observed in polypoid endometrium. Every ultrasound requires at least a minimum report. Here are the main points that should be mentioned in this report, including the sonographer name, the name of the patient, the identification of the machine, and particularly the date of the last check. And general information, the day of the ultrasound, the day of the last menstruation, the indication of ultrasound, and whether the ultrasound is transabdominal or transvaginal, and the difficulties encountered. Then, the actual content concerning the uterus, the position of the uterus, the thickness, if the contours are regular and the muscle homogeneous or not. The endometrium, the thickness, as we've seen, if there is any additional images, the homogeneous aspect, and if the aspect of the endometrium is consistent with the day of the cycle. The 2 ovaries visible or not, if there is presence of cysts, and the collection. And finally, we should have a conclusion, a brief conclusion, describing if the ultrasound is normal or if it requires other exploration. This minimum report has to be accompanied by iconography. This imaging should be present, a sagittal section of the uterus with the measurement in place, both ovaries, and in case of pathology, all images could explain the diagnosis. When there is fibroid, we use this schema to precise specific position of the different fibroma. In conclusion, the gynecological ultrasound is not a screening ultrasound. It is based on clinical indications and a rigorous technique, taking into account the recommendation I've just presented to you.